We welcome you to this 31st webinar series. And this is the SIG. Today, we are going to be having, some cases and some, discussions. So what we have planned is that we are having some recurrent stroke cases being presented from 4 centers across India. And we are having a special contextual brief talk on imaging in pediatric stroke. So we are going to be having we have this child neurocon which is coming 8th to 10th February, which I want to remind all of you. Abstract submission is open and it's going to be an amazing academic feast. And also we'll have many cultural events as well. Can we come to the next slide, Mansi? Dr. Mansi? Yeah. So in this session, what we have planned is we'll be having 2 speakers speak first. One is from SRCC Mumbai, another from SKIMS Kochi, followed by we will be having Dr. Hiren Panwala, who is pediatric radiologist at the SRCC Children's Hospital Mumbai, to talk briefly on imaging in pediatric stroke, which was contextual topic and requested by some. And then we will have the next of the 2 cases, one from PD Hinduja, another from AIMS Rishikesh. That is how we plan to proceed for the day. And we are very grateful, to all the presenters, and our experts today are Dr. Biju Hamid from Ghosh UCL and currently on an sabbatical establishing neuroscience services in the UAE. He'll be joining shortly, and Dr. Nihal Reddy, a very experienced, dynamic young pediatric neuroradiologist who's working at Rainbow Children Hospital, Hyderabad. And we have all our SIG members also on there. And moderator is Dr. Kalpana Datta, who is everybody knows. She is basically a very, very renowned pediatrician with special interest in pediatric neurology from Kolkata. And she has a lot of affiliations in the various academies of pediatrics, including Academy of Pediatric Neurology, the Child Neurology chapter of IAP. She was current chairperson, also the EB member of the Central IAP. So she's there, and actually it will be very important for her to disseminate and being conduit towards going towards from the pediatric neurologists to those who are pediatricians with a special interest in neurology. Thank you, Dr. Kalpana. And now I hand it over to you, Dr. Kalpana, to invite the first 2 speakers. And I think there is a change in the sequence as requested by from Kim's Kochi, that we'll have first from SRCC Mumbai, second from Hinduja, and then we will have the talk, and then we will have from AIMS Kochi and then AIMS Rishikesh. Over to you, Dr. Kalpana Datta.
Okay. Thank you, Dr. Sifali, for your kind.
Dr. Kalpana, sorry, one more. So one more housekeeping. 8 plus, it's going to be 8 plus 4. So cases will be 8. And now, Dr. Kalpana, you can remind them at 7 minutes, and then we can have a discussion for 4. Thank you. Sorry, all yours, please. Thanks.
Okay, thank you, Dr. Sifali. Good evening, all. And today we'll be having a third SIG on the stroke and presentations by different presenters from different parts of the country. And the experts are already introduced by Dr. Sifali. I'm not going to waste time by again repeating the same. So now I'll invite Dr. Kavya to present she is from SRCC Mumbai, and the moderator is Dr. Anita Hegde, ma'am. Has she joined? Madam has joined?
No, I'm standing
no,
for
no, Praganya.
Okay, no issue. Okay.
Dr. Praganya would be there instead of Dr. Anita. That's what it was.
Dr. Praganya will be there. And Dr. Kavya, please share your screen and start presentation. Your time will, after screening, you will show, then I'll tell the time. Okay?
Yes, ma'am. Is my screen visible?
No, yet not. Yes.
It is. Yes.
Yes, ma'am. Good evening,
Your time
everyone.
starts now.
Yes. Good evening, everyone. Today, under the topic of recurrent stroke, I myself, Dr. Kavya, fellow in pediatric neurology, is going to present a case who's a 6.5-year-old boy born of non-consanguineous marriage with normal birth and development, brought to us with complaints of 2 episodes of transient limb weakness. The first episode, he had a fever for 4 days, later which he developed weakness where he was unable to use his right upper and lower limbs, and which got resolved spontaneously in 3 to 4 days. At that point, there was no any medical intervention done. 6 months later, he had a similar episode. 3 days after the fever onset, he developed bilateral lower limb weakness. Within 3 days, his weakness resolved in the right leg and the left leg persisted for 3 more days. So there was 2 episodes of reversible ischemic neurological deficit for which MRI and MRA was done outside and was reported as Moyamoya disease and got referred to us by a neurosurgeon before planning for the bypass surgery. So on history, we couldn't find any seizures or altered sensorium during the event. There was no history of speech disturbance, no involuntary movements, no vision or hearing concerns, or any other bladder or bowel disturbance. There was no associated headache, vomiting, diarrhea, or rashes or joint pain during fever. And there was no history of trigger with excessive cough or excessive cry, hyperventilation. No history of fall, no significant family history, and no history of bleeding diastasis. On examination, his high mental functions were normal. His head circumference was normal. No dysmorphisms, no neurocutaneous markers. Otherwise, we found he had mild weakness and spasticity over both the lower limbs, which was more pronounced in left more than right, and his upper limbs were near normal, and the plantars were bilateral extensors. Other than that, no significant neurological deficit or comprehensive neurological examination. So impression, he is a 6.5-year-old male child, first by birth order, born out of non-consanguineous marriage with normal birth and development, with history of 2 episodes of reversible ischemic neurological deficit in duration of 6 months, without any significant birth or family history or no significant risk factors, with residual lower limb weakness and spasticity in left more than right. So our differential diagnosis were Moyamoya disease or syndrome, or any thromboembolic phenomenon because of underlying cardiac etiology, or any prothrombotic conditions. In rare cases, could be mitochondrial because it was triggered by infection every time. So I'll be showing the MRI shortly. The basic investigations were done where his 2D echo and ECG was normal, sickling and HB electrophoresis reticulocyte counts were normal. Other ESR, AMA, APLA, ACLA tests were negative. Fibrinogen assay PT-FTT was normal, and other basic metabolic workup with the complete blood count, the liver and renal function test, and lipid profile were within normal limits. So this is the MRI which he presented to us with, which was taken in the acute phase of second episode, where we can find in the ADC there is the hyperintensity in the left prefrontal cortex, and also the active restricted diffusion in the right frontal cortex involving the SMA region, which could explain this clinical picture with bilateral lower limb weakness with persistent left lower limb weakness for a while. So this was his MRA picture where we could find the stenosis of the terminal internal carotid artery. But in this picture, we couldn't exactly find the exact puff of smoke appearance we usually see in the Moyamoya disease. So our thoughts were it is a case of bilateral vasculopathy, but the non-classical findings were the proximal dilatation of internal carotid artery, no classic puff of smoke appearance, and the vessels were not tortuous, but it looked straight and narrow. So in view of all this, we have repeated an MRI which showed the same restricted diffusion, and the MRI picture showed bilateral severe terminal ICA occlusion and the prominent dilatation of ICS with very stretched and narrow vessels. In view of which, we have gone ahead with DSA, which again confirmed with the same findings, bilateral proximal dilatation of ICA with twig-like straight and narrow vessels in bilateral anterior cerebral and middle cerebral artery with the stenosis of internal carotid artery. So, in this point, with all the significant DSA findings and the arterial picture, we thought it could be a multisystemic movements and dysfunction syndrome due to ACTA2 mutation. So, in case of ACTA2, we expect this kind of twig-like straight stretched vessels, but in Moyamoya, we usually look for a tortuous anterior cerebral and middle cerebral arteries, and also the collaterals will be more in the Moyamoya disease in compared to ACTA2. And also the proximal dilatation of internal cerebral artery will be in ACTA2 when compared to Moyamoya. So at this point, we thought we could go ahead with the genetic testing of this child. So we sent the whole exome sequencing, which proved the mutation in the ACTA2 gene causing the pathogenic variant causing the multisystemic smooth muscle dysfunction syndrome. So let's see little about ACTA2 mutation. Where the pathophysiology is the mutation of the ACTA2 gene, which causes abnormal alpha actin, which is the important component of smooth muscle contractile apparatus. The mutation causes the replacement of arginine by cysteine or histidine. In few studies, it is shown whenever it's getting replaced by histidine, there will be more of neurological findings. The mutation causes the fibrosis and thickening of the arterial wall with early onset coronary artery disease, thoracic aortic disease with aneurysms and dissections, and a cerebral arteriopathy with features such as straightened branches. So even in the in vitro, these explanted smooth muscle cells show a rapid proliferation of myofibroblasts, and the histopathology of these vessels also proves the same findings. Usually, the age of presentation in this case will be less than 20 years. Other clinical findings of smooth muscle dysfunction include congenital mydriasis, patent ductus arteriosus, aortopulmonary flow, pulmonary hypertension, bladder and bowel dysfunction, and lipido-reticulosis. I'll be showing the other associated anomalies in the next coming features. So these are all we can expect in ACTA2, where the congenital mydriasis and previously explained MRI findings or axillary aneurysms, subclavian aneurysms, and other MRI findings could be the anterior bowing of the corpus callosum, flattening of the pons because of the straight basilar artery. There can be some indentation in the pons, and there can be twin peak sign in the pons because of the narrowed lateral diameter of the midbrain because of the straightened posterior cerebral arteries, and there can be radial gyration in the posterior temporal lobes and sometimes frontal lobes also. So after seeing this, we again reviewed the MRI of arch, which also showed indentation in the pons. So let's come to the management of ACTA2. So after moya below, we usually think of either direct or indirect revascularization could help the patient. But multiple articles show there is no much effect with revascularization, and moreover, there are complications post-op. It was intuitive, and we could able to explain this because of the basic pathology, which is this multisystemic smooth muscle function, and whichever artery we try to revascularize, that also will get eventually involved because of the mutation. That's
You
why
have to
it is
finish in
causing-
1 minute, huh?
Yes. So with all this, though we can't able to clinically manage exactly with specific surgical or medical management, we still help the patient with the proper surveillance program, which consists of genetic counseling, periodically investigating the pulmonary gastrointestinal assessments, and transthoracic echocardiogram, and the MRI at regular intervals. So our surveillance done, it was normal CT angio, HRCT, and ultrasound with Doppler. So our take-home messages, still there are multiple studies showing we are having undetermined and undiagnosed pediatric stroke cases, even now with all the advancement technologies in the radiology and also the biochemical investigations. So we still have to think about the genetic causes in case of undiagnosed pediatric strokes. So these are the few genetic conditions which can cause collagenopathy and systemic vasculopathy, causing recurrent strokes in pediatric cases. So our take-home message is, in case of recurrent stroke, we have to investigate in sequential manner, and if no etiology is found in the first or second tag investigation, genetics should be considered even in case of first episode of stroke, in case of significant red flags and with no flu. And the treatment options vary among the different etiologies. And in case of ACTA2 mutation, we can know the prognosis, and we can help the family with the regular surveillance protocol, and we can prevent from the acute crisis. So, and also we can prevent mortality, especially in the first year of life with ACTA2 mutation, where the closure of PVA, PH management, and aneurysmal surgeries can help the patient. Thank you.
Thank you, Dr. Kavya. Now, request Dr. Padmina is there.
Yes.
Yes, please come in if you want to say anything.
So just wanted to use this case to drive home the point. Pediatric stroke is very rare overall. We are all used to doing those first line investigations. And vasculopathy on imaging can mislead you. Like, this patient got referred for surgery to our center, being diagnosed as moya. And so it's really important. It's a rare condition. We all get very excited to want to treat it because it's treatable. At least we can prevent recurrences, generally speaking, with respect to pediatric stroke. But important to keep an open mind. If the imaging is not classic, think of other causes. And genetics is something I think we don't do very often when it comes to work of pediatric stroke. It's more cardiac, vascular, and prothrombotic. So do think of genetics because it really could change the trajectory of the treatment and the expected prognosis in given conditions.
Dr. Kavya, I want to say one thing. In clinically, you didn't get any features of cardiac disorders. So why did you keep the cardiac as a differentials? Because otherwise, you do have some pointers in the clinical clues in the examination part.
Yes, ma'am. As he had recurrent events, he had a differential.
But no finding, no
could be
clinically
embolic.
cardiovascular system
No.
was not having any clues.
No,
Clinical.
no. Yes, ma'am.
So I think that should be the third point in the differential, not in the second. After Moa. Okay, now I request the experts, Dr. Nihal, your opinion, please.
Dr. Kalpana, yeah, the imaging is pretty characteristic. It resembles the Moya Moya, but the distal branches are not what we commonly see in Moya Moya. They are more tortuous which have collaterals, whereas these are more straightened because of the actin involvement. Distal narrowing of the ICA can be a common feature for Moya Moya, but the rest of the arteries are not typical for Moya Moya, so this can be misdiagnosed if you don't know the condition. Acta 2 is a rare condition, and I've just shared another condition which affects the smooth muscle. MYH11 can also have the straightened appearances of the arteries. But what we have seen distinctively in ACTA 2, there is additional malformation which has been described, which has been shown by the presenter. They are pretty typical, the dysgeuria in the frontal lobes, the corpus callosum abnormalities, the brainstem indentations. With those MRI findings should point towards the diagnosis of ACTA 2 related mutations. So yeah, that is what I need to add.
Dr. Biju?
Thank you, Dr. Yan.
Dr. Biju is there. Dr. Biju.
Yeah. Oh, yeah.
Yeah.
Hello, Dr.
Hello.
Biju. Welcome to the
Hello,
event,
hello.
webinar. And your
Hello,
expert.
yeah.
Yes.
Interesting case. And it just again, it just goes to show how vessel imaging is critical in the workup of stroke. And I think intracranial arteriopathies at around 50% of strokes, I suppose, are intracranial arteriopathies. And as Nihal said, it's very rare. And you think about inflammatory conditions and moya and dissections as your major differential, and you think about then you work up the rare conditions. I only seen one other actor too before, and that was very interesting. We were called to PICU because the baby had unreactive pupils were fixed and dilated. They were concerned about the fixed dilated pupils, and when you went and looked, it looked like aniridia. It was like completely dilated pupils, and that was when the penny dropped, and then we tested for that too, and it came back positive. So I think it was mentioned in the slide as well, extreme mydriasis. So that was only my one experience of ACTA 2, and that paper was from Ghosh, I think, from Vijay Ganeshan and Felicio, which was showed. Yeah, so interesting, but again, rare condition, but to think about it. And also in Moya also, you can get genetic linkations, isn't it, with RNF 213, yeah.
In primary
So
cases.
interesting, yeah. Okay.
Thank you, Dr. Viju. Dr. Shefali, any comment from your side?
Yeah. Maybe Dr. Sangeeta or anybody else wants to say anything?
Others will go to the second case.
Yeah, no, it's okay.
And I just
We go
want
to the
add,
second case. Yeah, Nihal.
Compared to Moya, the ACTA 2s usually have more of a small vessel ischemic changes, whereas the Moyas can have a more medium vessel abnormalities. So that can also be a differentiating feature. Our case also, if you see, has more of a small vessel ischemia in the deep white matter, so deep and subcortical white matter. That can also be a differentiator sometimes.
Dr. Sangeeta? Is there any comment from any experts, any panelists? Others will go to the second case.
Yeah, please go to the second case. I think that's...
Yeah. So now I'll request Dr. Sahili from PD Hinduja Hospital, Mumbai. Will be presenting the case, and the moderator is Dr. Neelu Desai. Dr. Sahili, please share your screen.
Yes. Good evening, ma'am. I am Dr. Sayedi, and I would like to present, but my moderator, Dr. Neelu Desai, cannot join because of some urgent reasons. So she has conveyed her special comments and messages to me also. So
Okay.
if you would.
Okay, no issue.
Good evening. I'm Dr. Saidi Roy, currently pursuing DRNB residency in pediatric neurology at PD Hinduja Hospital, Mumbai. I would like to begin my case. She is a 13-year-old girl, first by birth order, born out of non-consanguineous marriage and right-handed. She had complained of recurrent episodes of right-sided hemiparesis, along with inability to speak during that episode. This was happening since last 1 week before presentation. Each episode lasted for around 15 minutes, and there was no residual deficit in between. Also, on asking probing questions, she complained that there was a history of on and off headache since last 2 weeks. She never had similar events nor any headache in the past. Birth and development was quite normal. Family history was negative, and examination did not reveal any focal neurodeficit. So MRI brain and MR angiography was done. And it showed, as is evident from here, that this T2 weighted hyperintensities in the caudate, putamen, as well as in other sections. It was corona radiata was also involved. And MR angiography showed narrowing of the left middle cerebral artery. So we went forward with the stroke workup, and in workup revealed anemia with the high platelet count. Iron profile also revealed iron deficiency anemia. ESR was mildly elevated. Rest workup was quite normal, including bubble 2D echocardiography, HPLC, and all other normal workup was done, and it was normal. However, considering that, so she was started on iron because of iron deficiency anemia. And however, considering the narrowing of the vessel wall, we went ahead with the vessel wall imaging. And here, if you can see that there was concentric enhancement of the vessel wall along with narrowing of the left MCL. This concentric enhancement is typically described for vasculitis. So this suggested that there was a vasculitic process going on, which was also supported by the high ESR. Next, as literature revealed that the serum acute phase reactants are not very not a very good marker of the CNS vasculitis. So we went forward with VWF, von Willebrand factor antigen, which is known to be a good marker for CNS vasculitis, but it was normal in this patient. All the systemic vasculitis workup was done, it was negative. CSF was also done to look for any infectious cause of vasculitis. It revealed mildly high protein, and all other investigations like viral panel, including varicella, was negative. TB test, gene expert, was also negative. So based on diagnosis of exclusion, we stamped this patient as a case of angiography positive childhood primary angiitis of the CNS. She was treated with methylprednisolone pulse, followed by oral steroid, planned to be tapered over 3 months. Aspirin was continued. On 2 months follow-up, she complained of one episode of similar event of headache as well as transient heaviness and paresthesias of the right hand without any speech disturbance this time. This lasted for a few seconds and it went up. So we have advised a repeat MRI brain, but they are yet to do that. So coming to this, so final diagnosis, as I said, was childhood primary angiitis of CNS. A short review of this condition. This is a very rare entity with incidence of 2 to 4 cases per million patients. So diagnosis that is based on the modified Calabrese and Malek criteria, which tells that there should be some newly acquired focal or diffuse neurological or psychiatric symptoms in a patient who is less than equal to 18 years of age, along with characteristic angiographic and or histopathological features of CNS angiitis in the absence of an underlying disorder. So it is basically a diagnosis of exclusion. Now, there are different types, angiography positive and angiography negative. Angiography positive are usually those which involve the large and medium vessels, and angiography negative involves small vessels. Angiography positive can be non-progressive type, which is a monophasic course, and a progressive type, which is a multiphasic course, and it can often progress even after 3 months. So considering our patient, though 3 months has not yet been over, but already she has a new symptom, so we might be looking at looking ahead to a progressive disease, but we are not sure yet. So next, angiography negative, it's usually not picked up by MR angiography. So brain biopsy is often required for diagnosis, but their presentation is quite different from the angiography positive ones. They present with cognitive decline, seizures, psychiatric, behavioral manifestation rather than neurodeficits. Neurodeficits can be present, but they are not the main presentation. So coming to the diagnosis, neuroimaging forms an important modality for diagnosis of these conditions. And like common modalities are MRI brain and MRI angiography. But the role of vessel wall imaging, it is very crucial and it is often underused. So as is evident from this image, the concentric enhancement is very much suggestive of vasculitis, whereas in case of arterial dissection, there is usually an eccentric enhancement. So it can guide towards the therapy as well. However, whenever we see vasculitis, we have to rule out secondary causes like infections, systemic vasculitis, connective tissue disorders, malignancy, and non-inflammatory vasculopathies. Finally, as I have already mentioned, the serum acute phase reactants do not correlate with the disease activity. So von Willebrand factor antigen titers is a very important test that can help in the diagnosis as well as in the monitoring. That after in follow-up months, if we keep on doing the VWF antigen titers, we can understand where we are heading. So treatment, this is a very good article published in 2019, where the treatment of this childhood primary angiitis has been given divided according to the category of it. So here we can see that non-progressive varieties will require methylprednisolone followed by 3 months tapering of prednisolone and a long-term antiplatelet therapy with anticoagulation at the initiation. Whereas the progressive varieties will require a long tapering of prednisolone for over 12 months, along with cyclophosphamide pulses for 6 months, followed by maintenance therapy with MMF or MMF for total of 2 years. So MMF for 18 months and cyclophosphamide for 6 months, and as well as antiplatelet and anticoagulation as in every case. And same goes for angiography negative angiitis. However, literature has shown that angiography negative angiitis has a higher recurrence rate and often needs longer treatment. So though the protocol has mentioned for 2 years, but it has been seen that often these patients need a treatment for about 3 to 5 years or even longer. So coming to the prognosis, large or medium vessel angiitis has a benign course compared to small vessel ones. Relapse rates are higher with small vessel, about 25 to 30%, and so might need longer monitoring and treatment. So in summary, the points that need to be highlighted are that angiography positive cases affect the large or medium vessels, whereas angiography negative cases affect the small vessels. Along with all the workup of stroke that is commonly done, in case of any vessel narrowing, vessel wall imaging is an important modality which can guide us to the diagnosis as well as the treatment.
Dr. Shahini, you have a 1 minute more.
Yes, ma'am. And von Willebrand factor antigen is an important biomarker that can be used for diagnosis as well as treatment because it correlates with the disease activity in CNS vasculitis very well. With this, I would like to conclude my presentation. These are my citations. Thank you.
Some
Thank you,
genetic
Dr.
workup
Shahini.
done?
Yeah, now we can say what message she has sent for us. Dr. Nilu Desai has sent some message, as you said. Then I'll call our experts to give the comments.
Yes, ma'am. Ma'am has said, emphasized on the use of the vessel wall imaging, which is often underused, and also the role of the von Willebrand factor antigen that in the disease monitoring as well as diagnosis. Though in our patient it was normal, but then even if we try to follow in the future and with any increase in the amount of the von Willebrand factor, then we can understand that might be a relapses upcoming.
Okay, thank you. Now I call Dr. Nihal. Please give some expert comments on this. Dr. Nihal, please.
Yeah, I'm there. So the imaging findings I can attribute is that focal narrowing in the proximal and middle segment of the MCA. The thing of the MRA, this can miss the small vessel vasculitis. So I'm not sure if the MRA negative vasculitis can be really termed as negative. Vessel wall imaging is helpful. On imaging wise, we would call this as an FCA.
One second, sorry. Can you stop sharing the screen so that we can see Nihal on full screen?
Yeah, so imaging wise, I would term it as an focal cerebral arteriopathy, possibly of the inflammatory type. That is all I can go for on the imaging. The rest of the diagnosis would be on the labs. And for vasculitis, I think Dr. Sangeeta has mentioned, even vessel wall imaging is not diagnostic. We usually need a biopsy to evaluate the inflammation in the vessel wall. And she's asked for pitfalls. Pitfalls can be age-related vasa vasorum changes, which can have enhancement, but they are more common in the adult age group rather than the pediatric age group. And the vessel wall enhancement, if there is slow flow in the vessel, this can also mimic the enhancement which we see on the vessel wall imaging. So that is a potential pitfall. And how we evaluate if there is a significant vessel wall enhancement or not, we look at the pituitary stalk for the comparison of the signal on the contrast. If the vessel wall enhancement is equal to or more than the pituitary stalk, then we take it as a pathological type of vessel wall enhancement. If it is slightly less, then we possibly attribute it to a vasa vasorum related change or a slow flow related change. So these are the common pitfalls which we can see in vessel wall imaging, interpreting vessel wall imaging. But on imaging, I would call this case as an FCA, and a follow-up scan in 6 months. If there is progression, then call it as a progressive vasculopathy. If it resolves, then it's a transient FCA. Yeah, so imaging-wise, I would say it's a FCA type variant.
Thank you, Dr. Nihal. And even Dr. Shuman Das has also said why it is not a case of FCA, focal cerebral arteriopathy. So now I request Dr. Biju for your expert comments.
I was also my colleague to Nihal. Nihal, would you advise genetic workup in this sort of situation?
Yeah, if everything was negative, then yeah.
But data too.
Simply wait for 6 months or repeat scan. If it has resolved, then transient FCAs, I'm not sure what is the genetic need for a transient FCA versus a progressive kind of vascular.
In terms of like small vessel vasculitis, you know, if like DADA2 mutations positive, like will change management, won't it?
Yeah.
Like in terms of
further immunomodulation, we have seen at least there are some microhemorrhagic foci also associated with the vasculitis, but not always. But if it is there, then it possibly attributed to a genetic cause.
Use anti-TNF therapy. Yeah.
Have they done a genetic test? Because if everything else is negative, we generally go ahead and do, right? Have you done?
No, ma'am, we have not done the genetic.
Okay. Yeah, Dr. Biju, please continue.
No, Dr. Biju, my question is, would you go with the genetics now or wait for a follow-up and see if clinically what would be the plan for this case?
Dr. Biju, your comment?
Because imaging-wise, I will not be able to.
I don't know, like using imaging to diagnose vasculitis, it's like what Sangeeta said, I don't think our radiologists will commit to vasculitis, which is in terms of workup. I would have thought genetics would be included. If we can do genetics for everything, then why not? If you're suspecting vasculitis, then because it changes treatment anyway, won't it?
Yeah.
I don't know. Yeah.
I also feel so.
Yeah.
Thank you, Dr. B. Any comments from any other panelists or experts over here? Dr. Shefali, you want to say something?
I know. I said nothing beyond that. We would have also done genetics. Yes, it would have helped us to understand. Yeah, I agree with Dr. Biju completely. Sangeeta, you want to add anything?
No,
you are on the panelist side. You can say.
Yeah, I agree with Dr. Nihal that it looks more like an focal cerebral arteriopathy rather than a vasculitis. So I think a repeat imaging and then further genetic testing would help to identify the etiology.
Yeah, and whenever there is any doubt in any case, it's always better to get it done, right?
Thank you, Dr. Sangeeta. I think if there's no more comments on this case, we'll go ahead.
We'll go with the talk. Now for the talk.
Yes. So now I request Dr. Hiren Panwala speaking on imaging in pediatric stroke. He's from NHSRCC Children's Hospital, Mumbai, and he's a pediatric radiologist. So Dr. Hiren, please share your screen and present your deliberation.
Good evening, everyone. So I'm having how much time? 20-25 minutes?
20 minutes.
Yeah.
We're having 20 minutes. Any questions? Then 4-5 minutes questions. Then we'll go to the second 2 cases.
Okay.
No.
So
Thanks, Dr. Hiren. Actually, this was contextual and this was a query raised by somebody and he requested for that. Thanks for pitching it at no time. Thank you
No
so
problem.
much.
So, since the time is less, I'll be just talking the relevant information, and I won't be repeating what our discussion has been happened in last two cases. So, we'll start with the pediatric stroke, how imaging can help. This talk will go under which are the types of the pediatric strokes. We'll try to highlight the imaging techniques and the recommended protocols. We'll show some case-based discussion of various etiologies and what's the role of advanced neuroimaging. We'll just briefly touch on upon the stroke mimics, which can clinically present like a stroke, but imaging helps in differentiating them, and conclude. So the purpose of the imaging in pediatric stroke is first of all is to we have to diagnose and assess the underlying cause in some of the cases. We have to see is there any treatment is proper, and by repeating the study. We also monitor the progression of the disease on MRI, as Nihal was saying that FCAI can be labeled or discarded after 6 months of follow-up MRI, we can confidently say. So those kind of scenario can be dealt by doing repeat imaging. And imaging can will help from differentiating from the mimickers that I'll be showing a few examples. The teaching pearl that in pediatric population, we should always focus on MRI because MRI is the modality of choice in a stroke workup, and we should highlight that in CT we will miss many findings. So whenever possible, we should do MRI. Only in some scenario when MRI is not available or MRI is not possible, then only we should go with the CT scan. So these are the three different types of pediatric stroke, and that is the arterial ischemic stroke, hemorrhagic stroke, and the dural sinus thrombosis. And there are many etiologies for the pediatric stroke, and even a single episode can be a multifactorial reason that we have to take into consideration. So, I'll be talking about the imaging protocols that we are planning to Dr. Nihal and many of this society I was in, they are working on the pediatric stroke pathway of the Indian-based protocol, how we should go about, and this is the thing that we are formulating, and it's in the pipeline. So, if there is suspected clinical stroke, then if the presentation is within 6 hours, in which we can start that. TPA, then we should go ahead either with MRI if it is available. But if MRI is not available or it is contraindicated, then we should go ahead with the CT scan, low dose, and we should do CT angiogram. And in other cases where the venous sinus thrombosis is suspected or we see something that is more favoring towards venous sinus thrombosis, then we should do CT venogram. So that's the protocol when the patient present within the 6 hours. When the MRI is not possible. When MRI is possible, then we should do these are the basic sequences that we should highlight, the diffusion and ADC, then followed by the susceptibility weighted images and 3D of MRI of brain, because at this moment we want to see that acute stroke is there or not, and we want to see that is there any major occlusion of the vessels or not. We can do optional studies like axial T2 and coronal flare in more than 2 years. And the perfusion and arterial spin labeling images we can do as optional basis. That depends on case-to-case scenario. If the child present after 6 hours, in which that TPA is contraindicated, then we should go with the detailed MRI, which includes the DWI, susceptibility weighted images, axial T2 and flare, coronal T2, and 3D TOF MRI of circle of Willis. And if it is venous sinus thrombosis, then we should do the phase contrast MR venogram, and we should do sagittal T1 3D formats so that we can attach the formats in different planes. There are some scenarios in which we have to do additional sequences or additional images. For example, if you are suspecting some sort of posterior circulation stroke or looking for resection, then we should include T1 fat set post contrast images from arch, aortic arch to skull base to look for those kind of scenario to look for dissection. The MR angio of the neck vessels are indicated whenever there is some sort of cardiac conditions or arteriopathy suspected or posterior pulmonary stroke is there, which are commonly seen which is seen, the occlusion might be seen in the neck, or in a case of dissection or cervical trauma, we should include the MR angio top of the neck also. Vessel wall imaging, we have seen that discussed in the previous two cases. In the case of arteriopathies versus vasculitis kind of scenario, we can use vessel wall imaging. And post contrast imaging we can do if there is suspected infection induced vasculitis or infection induced infarcts, or if you are suspecting vascular malformation, then we should use post gadolinium contrast, that is T1 and flare. especially flare when you are suspecting infection, because flare has got better sensitivity of leptomeningeal pickup as compared to the T1. MR spectroscopy can be done in a case of MELAs, some sort of certain mimicals like mitochondrial, in which we can do MR spectroscopy especially at the intermediate T, that is 144 to 125 T. And CT can be done in a case of mineralizing angiopathy when we are not seeing any obvious glowing on gradient, but there are no other risk factor, and we are highly suspicious for mineralizing angiopathy, then we should do CT scans. Then if you are suspecting deep venous territory infarct, then CT followed by CT venogram, or MRI followed by 3D phase contrast MR venogram, or contrast in MR venogram should be done. So these are the some specific scenario that we can add few more sequences. Uh, Now, starting with the arterial ischemic stroke, it has got multiple etiologies that we can go here. And the arterial ischemic stroke, it is defined by the acute focal neurological deficit, which is consistent with the arterial ischemia. And MRI will confirm the finding. It will be territory-wise, and that will confirm that it's looking like more of a arterial stroke, and it will exclude the hemorrhage also. So here is our first case in a 3-year-old child who had history of DORV, and patient had recent history of surgery. And after 2 days of surgery, patient started having generalized seizures, and MRI brain revealed a large MCA territory infarct, which was involving the left side cerebral hemisphere, the basal ganglia, as well as the superficial and cortex, as well as underlying white matter. It was a large hit of infarcts. So MRI will, first of all, it will diagnose, and it will show the severity of the infarct. It will also show that how much is the mass effect, are there signs of herniation. These are the things that MRI will add, that will help the surgeons and clinicians to take the decision whether a decompressive craniectomy is required at the time or not. So that is the advantage of doing MRI. The other thing that the MR angio, which in this kind of disorder in which cardiac thrombus or cardiac embolism might be a cause, then you should always include the neck angio also, vessels also, and we can see that from the portion of the neck only we are not able to see it looked like some sort of sudden cutoff of the ICA on the left side, and left-sided ACA as well as MCAs are not opacified. So there was a occlusion at the level of ICA, that was a thromboembolism at the ICA with cutoff, that was leading to this kind of infarct in this patient. So we can get to know that where is the level of obstruction, and hence we can plan the treatment. So in this child, the decompressive craniectomy was done based on the features of raised ICT and features of midline shift, and we can see that we could save the areas of infarct limited to whatever initial stage was there. The rest of the brain parenchyma was not involved on follow-up images. So these are the follow-up imaging, which is showing that chronic transformation of the previously seen acute infarct, but there are no new additional areas of any infarct in rest of the brain because of the timely decompression technique. Now moving on to the second case, here is 6-year-old girl who was third born of non-consanguineous marriage, and the child had some recurrent episodes of weakness in the past, and a history of seizure also. So the child had done MR angiogram earlier also, and then it referred to SRCC. And these are the imaging in which we can see that there is some sort of mild generalized volume loss and different territorial ischemic changes in the brain parenchyma involving the temporo-occipital, here right side occipital, as well as right side high parietal region, multifocal areas, as well as we can see deep internal watershed territory areas of multifocal chronic infarcts were present. And MR angio was done. So this was the initial MR angiogram which was done outside, which revealed that there was narrowing at the terminal ICA and the proximal ACA as well as MCA. And follow-up imaging was showing that there was worsening of this ICA stenosis, and you are not able to see the now MCA branches in the later on, and we are seeing this kind of classical puff of smoke kind of appearance on follow-up imaging. So these are few other reconstructed images showing the same abnormality that we can see here. We can see that narrowing of the terminal ICA. These are the source reconstructed images which shows that leptomeningeal collaterals and which are giving like to puff of smoke appearance. And just to give you example that this is the normal MR angiogram as compared to the abnormal collaterals and narrowing that we saw before in this present case. Vessel wall imaging also was done, so because there was a doubt of vasculitis versus idiopathic progressive condition, which was negative uh, at the follow-up. So this is just to show that MR angiogram can also help to see after post-surgery whenever there is an anastomosis between the ECA and the pile cortical branch of the MCA, that also can be revealed by the top MR angiogram images that we can see here. Here is one of the, this is not the same case, but one of the other case in which we can see this kind of anastomosis, which is showing better caliber of the right side MCA after the surgery. Another thing which I wanted to highlight is that role of perfusion in this kind of stroke, especially in Moyamoya kind of disease or Moyamoya syndrome. The literature says that there is a definite role of MTT and TTP, that is the mean transit time and time to peak. Uh, in a case of Moyamoya disease or syndrome, the areas which are hypoperfused, they are those who are at risk of ischemia, they will show increased MTT and TTP, and that will be marker that initial what are the values, and after on later on after surgery, is there any benefit by the reduction in MTT and TTP that we can follow up on imaging. One more thing I wanted to highlight, that these perfusion images, they are based on like which scanner you are doing, and which center you are doing. If you're done at one center or hospital, you to stick to that center or hospital only, because the result can vary if you change the MRI machine. So ideally we should do on the same machine with the same technique, so that we have some sort of consistent result when we are interpreting the data. Here is one of the case of the sickle cell disease, in which a child had presented with silent cerebral ischemia, and you can see that bilateral internal watershed territory are showing this kind of chronic infarct. The right MCA was not visualized properly. On this kind of Doppler screening. So this Doppler screening is also one of the important part which is practiced in many centers across India, and it is internationally accepted thing for the screening of the screening of the patient who are having sickle cell disease. So you will also see this kind of IV sign, which are the slow flow or leptometric collaterals along the surface of the brain cerebral hemisphere, because of the narrowing in the terminal ICA. Here we can see that the terminal ICA and proximal ACA as well as MCA shows narrowing, and that is the IV sign which I talked about. So sickle cell disease, the common areas of involvement are the terminal ICA, proximal ACA or MCA. So that we should be aware about whenever we are having this kind of vessel involvement, we should rule out sickle cell also. Here is that the case of FCAI, that is the transient cerebral arteriopathy, in which we are seeing infarct in the basal ganglia, and there is narrowing of the proximal MCA, which is the classical location in a case of post-varicella angiopathy. And this also has been discussed in the past, so I'm not going to detail. But the same patient, if follow-up imaging was done, which showed that there was improvement in that caliber of the vessel. So that indicates it was not a progressive thing. It was just a transient infection-induced narrowing, which resolved on follow-up imaging. So the transient cerebral arteriopathy, classically it is focal and monophasic, and they usually present with the basal ganglia stroke. In the contrary, the chronic cerebral arteriopathy, the stenosis will progress, or it will progress after 6 months. So as it was discussed that if you want to label something as a TCI, we should do repeat imaging after 6 months. If it is not progressing or if it is improving, then TCA will be a diagnosis. Otherwise, it can be some sort of chronic condition, chronic progressive condition. Here is one more example. Sorry. One more example of the same condition. I'm not going into detail. Just wanted to show that importance of vessel wall imaging. So vessel wall imaging, we are interested in enhancement along the walls of the vessels. We are not bothered about the lumen of the vessel. That I wanted to make one point clear, that we are suppressing the luminal signal. We are just highlighting is there any inflammatory or infection related enhancement on the wall. So that is the important point of vessel wall imaging. Here is one of the case of TB in which we can see that narrowing of the bilateral MCA and significant enhancement along the walls of the bilateral MCA, just to show that how they look like on vessel wall imaging. This is the case of ACTA2 that has already been described, so I'm not going to much detail, but you have to look for this additional finding with the narrowing of the terminal IC and straightening of the vessels. You have to see this kind of flattening of the pons, corpuscular dysplasia, this diarrhea in the brain, and sometimes they can have dilated aortic roots. So there are genetic causes also are there which can lead to this kind of pediatric stroke that we should be aware about. And when you see this kind of imaging finding, then you are and as a neuroradiologist, you are the first one to guide your neurologist that please do genetic studies and look for these genes, which will be very useful. Here is one of the case in which there was a genetic cause for the prenatal stroke, and here what we are seeing that there is a large porencephaly cyst in the left basal ganglia in the corona radiata region, and small chronic infarct in the right side external capsule region also. So when you see these kind of changes without much gliosis, and that indicates that the infarcts would have happened in the past, especially in the antenatal periods. And when you see that the areas of involvement is more of a small vessel related thing than call for a mutation, especially if you see some sort of hemorrhage also and large porencephaly cyst, then you can raise the query of genetic cause for the stroke like call for A1 mutation. Sometimes Mankey-Ganki disease also can present as stroke-like conditions in which the clinical examination will help, and the MR angio will show you this kind of tortuous vessels, and they can have this kind of stroke-like lesions in the occipital or temporal area that we should be aware about. That can mimic, that can be one of the mimickers of the pediatric stroke. Certain things about genetic causes of the vasculitis. One thing is that the arteriopathy implies in situ arterial abnormality that is not attributed to exogenous thrombus, and it is not a normal variant. So that is the mean of arteriopathy we wanted to clear about. And there are many conditions which can genetic condition which can cause Moyamoya syndromes like NF1, JAG1, SMA, HD1, and so on. But there are some characteristic imaging patterns that we saw ACTA2 and Fabry-Gris will have T1 hyperintensity in the pulvinar. These are the imaging finding. If we see, then we can guide our clinician to have look into those kind of genes. And all for A1 and A2, they can have both venous or arterial both kind of infarcts, which are usually the small vessel related infarcts that we should be knowing about. When you see posterior fossa stroke, for example, here is one of the case in which the 6-year-old girl who had presented with left facial weakness and right hemiparesis, and what we are seeing that DWI and ADC are showing restricted diffusion in the left side of the pons, and the MRNGO was showing this kind of narrowing and occlusion of the distal basilar artery top, and we also saw the posterior fossa, the bony structures in which there was suspicion of posterior fossa SIG junction anomalies. So whenever we are seeing this kind of posterior fossa stroke, we all should always look at the SIG junction. That will be the teaching point, because this SIG junction anomalies can lead to dynamic compression related stroke that we should be aware about. In this case, there was an atlanto-occipital assimilation which was asymmetrical that was leading to this kind of progressive narrowing while turning the head on the each side. And this case was shared by Dr. Astik Biswas and Dr. Prakash. And this is a Bow-Hunter syndrome in which we see dynamic compression of the vertebral arteries. So the take-home point would be that whenever you see posterior fossa stroke, you always carefully look at the CV junction. Is there any narrowing, or is there any CV junction anomaly? Then here is another scenario in which CT scan can help. A 14-month-old boy with history of fall and no other previous complaints and normal birth development, just has a trivial fall, and then a patient had weakness of the right upper and lower limb. And on imaging, we could see that the patient had left-sided posterior putamen stroke, acute stroke. And if you carefully see, the patient also had some sort of chronic scar kind of area in the anterior part of the putamen, which is looking like chronic. So the patient is having some sort of recurrent infarcts in this region. One is acute, one is chronic, and we did MR angiogram. MR angiogram was negative. On SWI, we could not see confidently the calcification. However, we repeated the we did the CT scan in which we could see these kind of linear areas of calcification along the branches of the lenticular right vessels, arteries. So this is a case of mineralizing angiopathy of the childhood, which is typically presenting as a at the age of the 6 months to 24 months. And because at this age, the angle is acute between the middle cerebral artery and lenticular side artery, which leads to prone for trauma-related infarcts, and the mineralized vessel, they are having defective contractility that leads to this kind of infarcts in the basal ganglia region. It is important to identify this condition because it has got excellent prognosis, and we sometimes in many cases we can avoid exhausting investigation, especially if the child doesn't have any risk factor and if we can see this kind of calcification. The another differential for basal ganglia calcification on CT would be a DADA mutation that we have seen in our hospital. Many cases that DADA mutation also can present with calcification in basal ganglia, and they can present with stroke. Here's one of the case in which the child had trivial fall in the school, and later on the child had developed some sort of right-sided weakness. These are the images which were taken on follow-up and which showed some sort of chronic infarct in the left-sided basal ganglia and the corona radiata region. And we could see that the left ICA again was not opacified, not seen here. And these are the T1 fat set post-contrast images, which shows that interval flap kind of region in the at the just division of the common carotid and the proximal ICA. It was looking like more of a dissection kind of appearance, and that was that was confirmed on the DSA also. So it is many times we can miss the dissection on MR angiogram and those kind of techniques. But if you are lucky enough, if you do this kind of dedicated T1 facet images, then you might be able to raise the suspicion of dissection in those kind of cases. Now moving on to the hemorrhagic strokes. So these are the common causes for hemorrhagic stroke: vascular lesions, clotting disorders, sickle cell, drugs, etc. And the good thing is that in hemorrhagic stroke, we will be able to identify the cause in 75% of the cases. Here is one of the example of hemorrhagic stroke in which a 12-year-old girl who had come with sudden onset left-sided facial weakness. And these are the representative images in which we can see that the child had multiple cavernomas lesion in the pons as well as in the right-sided peri-Rolandic region, and they have this kind of cystic popcorn kind of appearance. The right side peri-Rolandic region also shows ill-defined smudging and hypointensity in the adjacent parenchyma, which indicates that lesion might have bled, and that might be the cause for acute onset facial weakness. So one should be aware about those kind of conditions. When they acutely bleed, they can come with a stroke-like presentation. Then moving on to the deep dural venous sinus thrombosis. So dural venous sinus thrombosis, the risk factors are different in different age group. In neonatal, we should be looking for maternal infection or dehydration. These are the things which can lead to the venous sinus thrombosis in that age group. In child or adolescent, nephrotic syndrome, prothrombotic conditions, they are the common ones. And the anemia, cancer, chemotherapy, these are the usual risk factors which can predispose to venous sinus thrombosis in all ages. So here one of the case in which the child was a known case of nephrotic syndrome and presented with hemiparesis on the left side of the body. And what we can see here that on the right side we had internal watershed territory of infarct, and on the left side we could see that left-sided parietal and perironic area was showing infarct. But if you have to see carefully the dural venous sinus. Usually the dural venous sinus on T2 weighted images, they have flow voids because of the moving blood. If you see this kind of distension and hyperintensity in the T2 weighted images, that is highly suspicious for dural venous sinus thrombosis. And those areas will show restricted different. As we can see, these are the DWI images, which shows that high signal intensity in the superior cerebral sinus, and even the cortical veins also are showing distension and high signal intensity. So this patient also had this kind of cortical venous thrombus and extensive dural venous sinus thrombosis. We can see that on T1, the entire cerebral sinus appears to be hyperintense, which was extending to the deep venous sinus as well, the internal cerebral veins as well as the straight sinus also was showing this kind of thrombosis. And because of this thrombosis, the medullary veins, they were looking very prominent. The superficial vein also were looking very engorged on SWI images. So that is the usefulness of the SWI images. When you see this kind of prominent hypointensity, that indicates some sort of venous engorgement secondary to obstruction. And this is the normal SWI image, how it should look like. So in this case, MR venogram was done, and which was showing that practically all the dural venous sinus, they were looking thrombosed. And the veins from the external cerebral system, from the facial region, the veins they were traversing and they were trying to reinforce or supply the or drain the brain venous channels from outside. And this is the normal MR venogram, and we can see that in our case we were not able to identify any dural venous sinus because they were completely
Dr. Hiran, can you wind up in 2 minutes?
thrombosed. Now moving on to the stroke mimickers. So these are the stroke mimickers which can give rise to clinically give rise to stroke-like condition like MELAS or hemiplegic migraine or press or encephalitis. So here is one of the case. Dr. Viraj Udani, he had shared this case. So a 14 years old male child who had come with clustered seizure at presentation, and at that time only finding was the inferior colliculi were showing this kind of symmetrical hyperintensity at that presentation. But after that, the child on follow-up developed some sort of myoclonic jerks, hearing loss, left-sided numbness, significant paraphasia, and at the time, imaging pattern was like this. There was swelling, hyperintensity of the bilateral temporal area, which are not looking like typical vascular territory, and they were not showing restricted different. In an acute setting, we should ideally have restricted different because of the cytotoxic edema, but here most of the lesion was showing vasogenic edema, and they were not following some sort of classical arterial territory. So based on that, it was not typical for the arterial infarct. And looking at the history with multiple symptoms, and based on that, it was thought that this could be a mitochondrial disease, and MR spectroscopy was done, and that revealed lactate peak at 144 ppm, and which was proven genetically. So these are the things which can mimic like stroke, but like careful history and useful and using MR spectroscopy can aid value in differentiating all those. Here is one of the case in which perfusion can add value in an acute setting when you are in doubt whether it's a stroke or whether it's some sort of inflammation related finding on swelling in the brain parenchyma. So here is one of the known case of anti-NMDR receptor positive autoimmune disease. A child presented acutely with some sort of stroke-like of episode, and on imaging we could see swelling and hyperintensity of the right side temporal region, which was not showing much restricted difference. So that was one of the red flag that this doesn't look like more of a infarct kind of thing. This could be something else. And we did perfusion weighted images which shows increased perfusion in that area. So by that we could confirm that this looks like more of a encephalitis in the case of autoimmune disease rather than stroke. So to conclude, pediatric stroke is an important cause of the morbidity and mortality, which is often missed. And appropriate usage of imaging, it helps in confirming the stroke. And by using certain sequences or certain advanced imaging, we can identify potential etiologies, and we can monitor the treatment or progression also. And MRI is a valuable tool to differentiate stroke from the stroke mimicking conditions. So thank you for the patient listening. Yeah, and I'm ready to talk any questions or something. Thank you.
Ma'am, Dr. Gulati, will we be taking questions now, or will we taking them after the other two cases?
Okay, shall I stop sharing?
Okay, yeah, you can stop sharing. Thank you. And we can have few quick questions, if any, right now. Yeah. Dr. Sangeeta, you typed something, you can.
Yes,
Uh,
ask the question. Dr. Sangeeta can read your question.
Yeah, Hiran, is it common to have basal ganglia large size infarcts with hemorrhagic transformation in children with mineralizing angiopathy? What are the red flags in a child with suspected mineralizing angiopathy, which warrants genetic workup to exclude other causes such as acardiotis?
Okay, so like if you want to rule out mineralizing angiopathy versus acardiotis generally will have atrophy also at the time of presentation, and they will have more of a white matter leukodystrophy kind of pattern with areas of calcification. And acardiotis will have some sort of punctate calcification, which are not in a branching pattern. Like if you see on CT scan in mineralizing angiopathy, the calcification is linear. It is along the branches of the lenticular side arteries in the ganglia, so that they are morely linear. But in a case of acardiotis, it may not be seen. They can be punctate round areas of calcification, which may not follow the lenticular side arteries. Plus, you will have atrophy, and plus you will have some sort of white matter parameter leukodystrophy abnormality, which will help you to differentiate between the mineralizing angiopathy from the acardiotic syndrome. Hemorrhagic transformation in a case of mineralizing angiopathy is not so common. Like I have not seen much cases who present with hemorrhage in that hemorrhage with mineralizing angiopathy, and that might be a red flag that we might be dealing with some sort of vasculitis related thing or some other etiology, and then that might be a cause that we should rule out other things. That is my understanding.
On Dr. Hiren, there's another question by Dr. Vijay Patra. What are the imaging features of hemiplegic migraine?
Yeah, so hemiplegic migraine, usually on the conventional imaging, the MRI will be normal only. But if you do perfusion weighted imaging in that acute setting, you will see that the areas or the areas which are hemiplegia, that area will show reduced perfusion. If you do in that 24 hours of window time, then you will be see that there is asymmetrical reduced perfusion in those regions. So in that way, you can potentially use the perfusion weighted images. Otherwise, most of the cases, the hemiplegic migraine, the imaging patterns like conventional imaging will be normal.
Okay, Dr. Hiren, anyone? Any other questions?
Dr. Biju, your comments. Dr. Biju?
Nothing specific, Dr. Shafali. Excellent review. And again, it shows how neuroimaging is so important in coming to a diagnosis. I think neuroimaging is key because in terms of coagulation and other things, like there are still lots of unanswered questions, isn't it? In terms of how long to give, and even in terms of FCAs, focal cerebral arteriopathies, there's still a lot of unanswered questions. But the region where we have advanced so much is the imaging side of things, particularly vessel wall imaging. So hence it's an excellent summary of all these things. And also with the ICARD, I think, yes, as you know, we may not see calcifications in all cases, but the temporal horn dilatation and the atrophy that Dr. Hiran mentioned, and there will be other clues, obviously. Yeah. So,
I think neuroimaging is very important in this area. This is very important and is wonderfully done it really. Thank you so much, Dr. Hiren.
Thank you.
Dr. Nihal, you want to add
Dr.
something?
Nihal?
Yeah.
No, nothing to add. I've seen this talk multiple times, and excellent presentation by Hiren covering almost most of the aspects and on a short notice. So thank you, Hiren, for presenting.
And there's another question from Sunitha. She's asked, is there any genetic differentials for ACTA2 mutation?
Genetic different, like imaging mimickers?
I don't think it's related to imaging. Genetic differentials for ACTA mutations.
Nihal had mentioned.
Yeah, Nihal
mentioned.
Yeah, Nihal has put a paper there. He shared a paper.
MYH11. Yeah.
Thank you so much, Dr. Hiren. Dr. Kalpana, we can go to the next case. I think that's from KIMS,
now,
right? Yeah.
I think Dr. Dona will going to present, or Dr. Disha. Who is in the line?
The one from KIMS. KIMS from KIMS.
So thank you, Dr. Hiren and all the experts. Now we are coming to the case presentation. Now Dr. Dona Teresa will be presenting from KIMS Kochi, and the moderator will be Dr. Kalpana Vijay. Dr. Dona, please share your screen. Dr. Dona, are you ready?
Can you hear me, ma'am?
We can hear you, Dona, right now. Yes.
Can you see the slides, ma'am?
No.
Dr. Mansi, can you please guide? And one request again to all the presenters, please join at 7:30. The event people, they log in at 7:30 and everybody has to try to present slides. You don't come up late up and then present directly. I mean, for everybody. Only one person tried on the slides before. portal is on. The platform is open at 7:30. Can't waste so many man hours, right?
Yeah, I think if Donna is getting late, so I think second presenter can call because we are already 9:20.
I call the next one then in case she can't
I think
present.
Dr. Donna, you get ready. Till then, Dr. Disha is going to present. So Dr. Disha Gupta from AIMS Rishikesh, and the moderator is Dr. Pratik Panda. So Dr. Disha, share your screen.
Good evening, ma'am. Am I audible and my slides are visible?
Yes, it's visual. Until then, Dr. Donna, you just get ready with your presentations.
Everyone, today I'm presenting a case of recurrent weakness in a child.
Make it slideshow. Make it slideshow. No, okay. It's okay. Okay, we start.
Okay, ma'am. So, good evening, everyone. Today I'm presenting a case of recurrent weakness in a child with intellectual disability from the Department of Pediatric Neurology under the guidance of Dr. Pratik Kumar Panda, sir.
You can click on the screen and then move next.
So I think it has got a hand. It will just.
No, exactly what I'm saying. Click on your presentation screen and then you will be able to move.
Continue, Dr. Disha.
Yes, ma'am. So I'm presenting a case of girl mischief, 15 years old girl, resident of Saharanpur, UP, under a follow-up in OPD. So she presented to us with the chief complaints of delay in attainment of milestones since birth and autistic behavior since 3 years of age. She had 2 episodes of hemiparesis, that is right hemiparesis at 9 years of age, another one left hemiparesis at 14 years of age. So she had an uneventful birth history and she had global developmental delay at 1 years of age. That is what parents noticed, and there was delay in all gross motor, fine motor, social, cognitive, and language domains. The child, when presented to us, had mild intellectual disability. Also, the parents told us that they noticed that the child has autistic features which began at 3 years of age. At 9 years of age, there was an episode of right side hemiparesis, which was acute in onset, associated with headache and vomiting, and was progressive. However, not much of investigations was done at that point, and the child was treated outside with aspirin. And as the hemiparesis recovered over 4 to 5 months, the parents did not seek further medical attention. Then the child had another episode of left side hemiparesis at 14 years of age, again after which they met few private practitioners, but had not met a neurologist. So there was no history of any altered sensorium seizures, vertigo, fever, rash, or breathlessness. There was no cranial nerve involvement or involuntary movements or positive or negative sensory symptoms, and there was no bowel or bladder involvement. On examination, the child had moderate obesity as per the WHO classification, and as we can see, she had microcephaly. However, there was no lens dislocation, high arch palate dysmorphism, or marfanoid habitus. Her CNS examination, her higher mental functions and cranial nerves were intact. The fundus was normal, the bulk was preserved. The tone was slightly increased on the left upper and lower limb, and the power was normal in all the 4 limbs. Reflexes, the upper limb reflexes and knee reflexes were present. However, the ankle reflexes were absent. So there was a knee ankle gradient suggesting that probably the child might be having peripheral neuropathy. So we had a 15-year-old girl who presented with global developmental delay since birth, autistic features, recurrent episodes of stroke with no perinatal insult, and an examination had microcephaly and peripheral neuropathy. So we upfront kept the possibilities of homocystinuria in view of intellectual disability, autism, recurrent strokes, microcephaly, and peripheral neuropathy. However, there was no lens subluxation, marfanoid habitus, or seizures going against it. Possibilities like organic acidemia, methylmalonic acidemia was also kept as the child had global developmental delay, recurrent strokes, and autism, but there were no recurrent episodes of encephalopathy. Mitochondrial disorders like MELAS and complex deficiency also one might consider in view of recurrent strokes, but no external ophthalmoplegia, diabetes, short stature, or hearing loss goes against it. Urea cycle disorders, also like OTC deficiency, can present with recurrent strokes with aggressive behavior, but no recurrent vomiting, there was no confusion disorientation, and there was no hepatomegaly. Disorders of creatine metabolism like AGAT or GAMT deficiency was also considered in view of GDD, autism, intellectual disability, and knee weakness, but there was no seizures or extrapyramidal symptoms which are usually seen in them. Alternating hemiplegia of childhood was another possibility we thought of, as the child had alternating hemiparesis, GDD, and autism, but there was no ataxia or extrapyramidal symptoms or nystagmus. On investigations, the hemogram and blood profile was mostly normal, and there was no thrombocytopenia or megaloblastic anemia. There was no transaminitis, and as we can see, that the ammonia and the lactate levels were also normal, making urea cycle disorders and mitochondrial disorders less likely. We went ahead with other workup and we saw that the child had elevated serum homocysteine levels, and the B12 level was suggesting homocystinuria. And however, the B12 level was normal, making methylcobalamin synthetic defects less likely. The prothrombotic workup was normal. Screening echo was done, which was also normal, and the nerve conduction study, which was done, showed that there was sensory motor polyneuropathy of bilateral lower limbs, and the motor amplitudes in the upper limb were also reduced, but the sensory potentials were normal. The TMS TCMS which was done showed that the methionine levels were in the normal range. This is quite important because, like in patients who are having classical homocystinuria, that is deficiency of cystathioid beta synthase, there will be no formation of cysteine from homocysteine, and as a result, homocysteine and methionine both will be elevated. However, if there is defect in MTHFR and the methylation of homocysteine to methionine is affected, homocysteine will be elevated, but the methionine can be low or low normal. That is why we were considering MTHFR deficiency more likely than classical homocystinuria in our case. The MRI brain, which the patient had got it done already from outside, it was showing that in the axial T2 and flare sections, we could see that there was prominence of the cerebellar folia and there was cerebral atrophy. Also, in the other T2 and flare sections, we could see that there was diffuse cerebral atrophy. There was diffuse cerebral atrophy with some encephalomyelitic changes in the bilateral temporoparietal lobes with prominent sylvian fissure, and the cerebral atrophy was quite marked. Also, we could see in the sagittal sections that the whole brainstem was quite atrophy. And in the T1 section, we could see that there was calvarial thickening, probably because of the repeated head banging the child was having because of autistic features. The MRA and the DWIDC maps were, however, normal, which suggests that probably the child did not have an acute stroke at this point, but this patient has been untreated for such a long duration, and now that the diffuse cerebral brainstem and cerebellar atrophy has set in. The child was treated adequately with betaine, high-dose betaine, hydroxycobalamin, B12, and folic acid, pyridoxine, aspirin, and levocarnitine, as we were suspecting homocystinuria. Meanwhile, we also got the clinical exome sequencing done, which showed a homozygous missense variant in the exon 7 in the MTHFR gene, which was autosomal recessive and hence pathogenic. This is the current status of the patient. We could see that the child is ambulatory with minimal support and she had autistic features. However, with the help of AB and speech therapy, the child is doing quite better. And the repeated serum homocysteine levels, which has been done, has shown homocysteine levels of 50 at this point. So the take-home message is that one should always consider testing for homocysteine levels upfront in patients with intellectual disability, recurrent strokes, peripheral neuropathy, or epilepsy, as homocystinuria is a condition which is amenable to treatment with help of multivitamins and drugs like betaine. Thank you.
Thank you, Rishabh, for your presentation in unfinished within time. Before, rather, I say before time. So, Dr. Pratik is there?
Yes, ma'am. Yes, ma'am.
Yeah, just say your comments and like.
Ma'am, this case is clearly, it looks like a MTHFR deficiency. The point I wanted to highlight is, if you look carefully at the MRI, there are some gliotic changes in the MCA region, bilateral MCA region, more on the left side. So that actually pointed towards the recurrent territorial strokes, which was missed. The MRI was done previously also. So we looked at carefully, and then we thought it was due to probably MTHFR deficiency, as Dr. Diksha has pointed out. The methionine level was normal and all these things. But we need to look carefully in these cases. This can be changes of old stroke. That is the only thing I wanted to highlight.
Thank you, Dr. Pratik. Nice explanation. Now I'll request the experts, Dr. Viju and Dr. Nihal. Your comment, please. Dr. Viju?
I think Sangeeta could comment on this.
Okay, Dr. Sangeeta?
Thanks, Diksha, for the nice presentation. So, the MTHFR deficiency children, they have a very variable clinical phenotype. They can have onset right from the infantile period, or they can have late presentation in the adolescents or in adults. So the phenotype is very highly variable. They can present with unexplained IED, intellectual disability, or global developmental delay. They can have refractory seizures. They can have psychiatric manifestations, or they can even present with progressive spastic paraparesis. And they can also have present with recurrent strokes. They can have both arterial as well as venous strokes. So so whenever a child presenting with a recurrent stroke or in the background of ID child having a stroke, as Diksha was mentioning, we should always look at the homocysteine level. So if the homocysteine level is elevated, and then you look at next point to look at is with the methionine level and the urine methylmalonic acid. So if the methionine level is normal or low normal with the elevated homocysteine, then you should suspect MTHFR deficiency. If the homocysteine is elevated and methionine is also elevated, then you suspect a classical hyperhomocysteinemia or homocystinuria. And if homocysteine is elevated and you have urine methylmalonic acid also positive, and then you should suspect the proximal intracellular cobalamin defects, where you have a defect in the complementation of F, C, and D factors. So it's a very interesting patient, and it is very essential that we should diagnose, because one is it is potentially treatable, and other thing is for the genetic counseling. So because it's an autosomal recessive disease, we need to offer a genetic establish a genetic diagnosis and offer genetic counseling.
And thank you, Dr. Sangeeta. Yeah, this type of presentation, a varied presentation from since birth to 5 years, 6 years, we have seen many cases. So now I request Dr.
Yeah, so
Yes.
we can tell Dr. Diksha to stop sharing the screen, right?
One second, Diksha, I was asked by Dr. Nihal on chat to show the MRIs actually. So I think that's what she was showing. Dr. Nihal, you wanted any more images?
No, I think there's a comment of gliosis or encephalomalacia. Is that right? On both sides.
Can you
Dr.
show the
Pratik or
Diksha,
I-
show the MRI.
So
Make
what was
it
the
full screen,
interpretation?
beta.
So the interpretation was bilateral cystic encephalomalacia. Is that right or?
So definitely there is diffuse cerebral atrophy and the Sylvian
Yeah.
fissures prominent, and we
Yeah.
can see that there is as it is there is some encephalomalacia changes, but these are not that marked as usually we will see in patients of stroke sequelae.
Yeah. So what I think is the cystic changes are actually the Sylvian fissures, which are widened. And if you look at the insular cortex adjacent to the Sylvian fissures, it is maintaining normal thickness. So I think the MRI interpretation for at least these images are diffuse cerebral and cerebral atrophy. I do not see any encephalomalacia or gliosis per se. I think the CSF spaces which you are seeing are the Sylvian fissures, the x-axis spaces, and not the intraparenchyma or the intraaxial changes. If Hiren is there, he wants to comment on that.
So this is more markedly diffuse cerebral and cerebral.
Diffuse cerebral atrophy. Yeah, that I agree.
Right.
Yeah.
Right.
And Dr. Sangeeta, any did you have any experience of reversibility of these atrophic changes? We have seen some changes that have on supplementation.
So it depends upon how early you pick up the diagnosis. If you pick up in the infantile period and initiate early treatment, the children continue to gain milestones, but many of them are still left with significant language deficits and autistic traits. Though the seizures come under control and they gain the motor developmental milestones, they have significant deficits in terms of language and socialization defects. So the older ones which present with like a progressive spastic paraparesis, they have typical white matter changes in the parieto-occipital, and the callosal involvement also is seen, like it might be mimicking like a leukodystrophy.
Yeah.
And there is a question. Dr. Vijay Patra has asked, did the child have anemia and what is the MCV? Did you go for the blood test and what is the MCV?
Then the child did not have anemia and the MCV was 88. So we looked at the
MCV. No, it should be more than 90.
Yes.
It's low.
Yes, ma'am. So actually there was no megaloblastic anemia, ma'am. Like if a child would have homocystinuria because of methylcobalamin synthetic defect, then probably we would have seen it to be more MCV to be quite high, and megaloblastic anemia would be there, and suggesting that B12 will actually help the patient even more.
Okay. And there's another question by YB. Can early initiation of treatment can prevent the development of autism? Any experts can answer.
That's what I was mentioning. Like even if you pick up early, some children are left with significant autistic traits and language deficits. Not all cases respond completely, and then not all symptoms are reversible.
Actually, it is something, we're looking for a lot of therapeutic intervention targets and all, and trying to understand. And we'll have to go ahead more on the epigenetics of this particular condition to see where we can prevent. But it is very unlikely, and it is $1 million question actually, and a very important one to has to see to prevent. Somebody has also asked something on HIV neuroimaging. I think that we can take later on after the next case. Dr. Biju, you want to add something?
I agree in terms of that last point about what is the symptoms and treatment. I completely agree. I haven't seen it work as a.
No, it's not. Neither have I. I've also some patients, yeah. Any other last?
The brain atrophy reversed, especially B12 dependence on one. Dr. Nihal has said. Yeah, even I see the clinical improvement even when we started in the 6 months. Some cases are 3 years also. So 6 months patient was improved very nicely.
Yeah, Nihal, you're mentioning about infantile tremor syndromes with causing cerebral atrophy because they do really well when you supplement vitamin B12. They have good developmental gains and also have improvement in terms of myelination as well.
Yeah. So sometimes it might look very drastic on the first image, but sometimes these are treatable, I guess.
Yeah, Mahesh does have a lot of cases. Yeah. Actually, he's on travel right now. That's why he's not logged in. Can we have the last case, please?
Yeah.
And my request to all the presenters for future webinars, please log in between 7:30 and 7:55 and please try your sharing the screen.
Yeah.
Mansi or Asmita are always there.
Yeah. Now I think she's ready by the time. Dr. Donna, are you ready? Dr. Donna?
Dr. Donna?
So Dr. Donna, Teresa Thomas from KIMS Kochi, she's going to present a case and the monitor is Dr. Kalpana Vijay. So are you ready? Can you share your screen?
No, Dr. Donna, you must just put your presentation on full screen. You need to go back to Zoom and you need to click the green share screen button.
First, keep the presentation open in your desktop. Then you
just one second, Dr. Kalpana, 1 second. Donna, please mail it to Manasi. Manasi, you put your mail on the WhatsApp, right? And meanwhile, you can have the discussion on for that other questions. Please do not waste any more time. Please mail it to Manasi. Manasi will share the screen and we will do it, please. And we can just have the discussion and on for the question which is there. There's a question on Dr. Hiren, there's a question for you for regarding imaging in HIV. Can you say the question? Manasi has put the email ID in the chat. You please mail right away. Meanwhile, we continue. So you see, so many persons, time cannot be wasted, right, Donna? Just because of some technical glitches, because you don't want to practice beforehand. It's okay. Dr. Hiren, there's a question.
Well, I personally don't have any experience of pediatric HIV-induced stroke, so I won't be able to answer that question. I would ask other if they have seen something like that. I'm sorry.
Nihal?
No experience with HIV, but they tend to have small ischemic changes. That is the only one. We cannot differentiate that from the other infective ischemic changes.
As per my,
we don't have a series.
And initially they may present with atrophy, which is not seen in other infective.
Yeah. As per my experience on pediatric HIV, I have seen only the cerebral atrophy, diffuse atrophy, and dilatation. Not a single case of stroke, though we are having 1,900 pediatric HIV children in my center.
It's too many, huh? Dr. Biju? Dr. Biju, you want to pitch in for HIV?
Oh, I haven't. We haven't seen any.
So already we have 9:30 past 9 minutes.
Can you, Dr. Hiren, can you just, meanwhile, by saving time, can you give us just take-home messages for the pediatric neurologist? 1, 2, 3, 4, 4 messages.
4 messages, I would say that
messages, because what you think we are missing.
That will be the first.
Sorry, can you come again?
So the first message would be that whenever possible, don't go for CT, directly go for MRI. That will be the most important message in the pediatric
One.
age.
That's
One
one.
thing is that,
Yeah.
yeah. Second thing is that in an acute stroke, whenever child is coming within less than 6 hours, whenever there is indication of TPA, we should restrict our imaging to less than 10 minutes that we have discussed in that protocol. That should be there. And a pediatric neurologist should be able to govern the case so that whenever they find that this is not looking like pediatric stroke or mimic, then we can plan the next sequences according to the etiology we are suspecting. For example, if we are suspecting mitochondrial, we can plan based on MR spectroscopy. If we are suspecting venous sinus thrombosis, then we can plan the dural venous sinus thrombosis. So it's very important to a person who is dedicatedly trained in a stroke, especially in pediatric stroke. They should be governing the case when the case is going on. That should be the take-home message.
Thank you. Mansi, have you got the
Yeah,
slides?
these are
Actually,
things which I can think
Dr.
of.
Hiren, actually, you know what? We have been recording all the sessions. Do we have a permission to use your part also
Yeah,
on
no
the
problem, no
YouTube?
problem.
Okay,
Yeah,
I forgot to ask you. I mean, I forgot to ask you. I just wanted to share that we have the stroke mimics is the first Wednesday we had. It was wonderful
Okay.
collection of cases. You know, we can go back. And the second time we had acute strokes, interesting cases. This time was recurrent stroke plus yours was a contextual request. And
Acha.
next week we do have a talk on management of stroke. Please, can you share the screen, Mansi?
Mhm.
We are already past time, but we should let the presenters.
I haven't received the PowerPoint yet. Dr. Donna, have you emailed the presentation?
The other thing that Nihal was talking about, that reversal of brain atrophy in that vitamin B12. We recently came across one case in which there was cobalamin deficiency related case, which was proven on genetic aspect, and that also was showing initial atrophy and then reversal of atrophy on follow. So I think this pathway has something to do with some sort of atrophy and then reversal that I just wanted to share.
Thanks. Thank you. Mansi, you've got the slides?
Dr. Donna, you can share the document over here on the chat, in the Zoom chat.
On
Or
the
you can-
Zoom, actually, I've sent it to the Gmail of the AOCN.
No, ma'am,
India.
I don't
Donna,
have
one
that
second.
PDF.
Donna, I
Actually,
think we'll have to postpone the session. I think we're just we're in time. Nobody will open the AOCN India mail right now. I think we'll just wind it up now. Dr. Kalpana, Vijay,
Yes,
I think we will have to cancel it. I think I'm sorry if
okay,
she
she
can
will get
present
the
right now, but
opportunity
she's
sometime later.
yeah, sometime later. What do I do now? Just tell me.
Yes,
We'll have to
yes.
wind up. In
Yes,
that
We
case, we
can
can't
wind up.
waste so much.
No
Only-
problem. We will
Yeah.
present at some other time.
Okay,
Sorry,
ma'am.
ma'am, it happened like that. Okay.
So Donna,
No
don't
problem.
get
No problem.
disheartened.
No
You'll
problem.
get the chance in future.
Okay.
Okay.
No, she should have mailed. No? She's not mailing to Mansi's mail account. She
Having
wants to mail
problem,
to AOC
might
in
be
India.
having problem in
No
her
problem.
net.
No
She
problem.
might be having
No
problem in her
problem. No
net.
problem. It's okay. It's okay. No problem.
Fine,
They
it's
have to
fine.
practice beforehand. Yeah, it's perfectly fine. Dr. Kalpana Vijay, you want to make some comments, ma'am? Ma'am, we can make her present in any of the future ones. And if I mean, she should be
Yes,
mailing.
there's no
She's not been
problem.
mailing. We've been
Actually, yes.
waiting. Yeah. Any comments? Not any comments. And if you want to make any comments for the presentation done, and you can also make a comment on the case you were about to present the take home messages. Can you just say that?
Actually,
Yeah.
we were planning to present a case of a 4-year-old child with history of 3 episodes of stroke, brainstem strokes. He was born out of a non-consanguineous family, born out of a consanguineous parentage, and initially the child had a right hemiparesis, and next time the child developed a left hemiparesis with that's a closed hemiparesis involving the bones, and the third episode was in a midbrain stroke that was on the opposite side. So all were the posterior circulation strokes, and then in the second episode of stroke, the child had a hypertension also, which was transient. But on further in evaluation, usual tests are all negative, like renal Doppler, everything came as normal. And further, because the hypertension and all, we evaluated in the third instance, and it came. There was a scarring in the scan, that is in the CT scan of the renal scarring was there, and it came to be a DADA2, that is deficiency of adenosine deaminase 1 deficiency, DADA
1 deficiency. So it's the monogenic cause of recurrent stroke, and this patient had initially had multiple brainstem strokes, then developed hypertension, and later on developed the erythema nodosum and other findings. So the first presentation, initial presentation, was with CNS manifestation. And so, and then the child developed features of vasculitis, and then there was in CT scan, there was renal scarring also. So any child presenting with a polyarteritis nodosa-like presentation, in especially young child less than 3 or 4 years and brainstem involvement, think about monogenic causes. That was the like a DADA1 deficiency there, and it was found to have a pathogenic mutation, as well as the enzyme also was found to be low, and the child was started on a TNF inhibitor at etanercept, and then the child was in no further seizures after that.
Thank you. It seemed like a very interesting case, and we missed some imaging and all the things about it. But actually, we are running
So
14 minutes,
it's important
16 minutes.
Yeah, it's important to diagnose because there is a risk of hemorrhage, isn't it, Dr. Kalpana? And
Yes,
you have to
later on
stop
there can be a risk
antiplatelet.
of hemorrhage also.
Yeah.
And this is a very damaging condition because central nervous system, posterior circulation stops. The child can have sudden deaths
Exactly.
also. And also
Yeah.
there are other complications like hypertension, as well as the renal problems can develop. And so all these, and the treatment is not by steroids, but TNF.
TNF
alpha
inhibitors,
inhibitors.
absolutely. Yeah, true. And stopping antiplatelet therapies. Yeah.
And actually, the antiplatelets will increase the hemorrhage. That is the other
Exactly. True. Yeah.
I think it was a very amazing case, right? I mean,
Yeah,
Dr.
very
Biju,
interesting,
anything?
Rabdin.
Yeah, very nice. Yeah, very nice case. We seem to have missed the
So if I
imaging.
So thank you,
Yeah,
Dr.
okay,
Kalpana,
fine.
for summarizing the case and giving us the information about the case, and very interesting.
In
Thank you,
case Mansi has received, she can show the images. Have you received, Mansi, the slides?
The certificates, right?
No, the slides. Has she received the slides?
Okay, 1 minute, ma'am. I'll just check that. Okay, Dr. Donna.
Yeah, then you can just share it. It's okay. I mean, it's okay. Less number of people. And then just 1 second. Then you know what happens. Dr. Donna will not go through the whole thing. She just say show it so that the time doesn't. For all the effort and if it's okay with all of the experts, we can do in the next 5 minutes so that.
So can you allow me to share the screen? Let me see.
Mansi is sharing. Ma'am, Mansi is sharing.
Mansi
Mansi
sharing.
share.
Okay.
No, ma'am, I don't
Ma'am,
have
you
the
can.
slides. I don't have the slides.
You don't have the
Okay,
slides.
then.
Okay, Kalpana ma'am, you can say you can allow Kalpana Vijay ma'am to share, please.
Yes, ma'am. You want to allow?
Let me.
Yeah, you can do that, ma'am, please. It is not right that you miss an opportunity. You prepared it. I feel bad, but there's so many people.
That is because it happened like that. That is not a problem.
It's okay. No, ma'am, please do it, ma'am. We are actually 40. We have 18 minutes behind, but we will do. I mean, many people have gone, but it's okay. With the help of experts' permission, another 5 minutes. Dr. Kalpana Vijay, can you just put the share screen and share the entire screen? Yeah, and then, ma'am, you can open your slides. SIG feedback कैसे आ गया? Yeah, put it full screen. Yeah, put it full screen. Yeah, you can just, it's okay. You can, you already told the history part, right?
Yes, I'll show you.
This was
this was the child in the 3rd episode. Actually, you can see that the left eye, there is an exotropia and there is a myotosis. The child has improved actually, and the nasolabial fold is more prominent on the left side, and child has an ataxic hemiparesis on the right side actually. So the right side facial and right side weakness, and then there is an ataxia also was there, and then this was one image that was showing the diffusion restriction. Actually, this is a side is turned. It is also, this was the initial image that was on the right side. Its side is a little different, and this is the second case when there is an acute infarct in the right basal ganglia and involving the anterior limb of internal capsule also. and there is an involvement of the thalamus. That is what is shown, which is showing the diffusion restriction. Then in the third image, we can see that there is a long area of diffusion restriction in the midbrain that is on the left paramedian one, that is producing this left-sided ptosis and left-sided ptosis and left-side third nerve palsy, which was incomplete. There was no internal ophthalmoplegia was not there, and there was a weakness on the right side. And this is the renal scan that is showing somewhat a small kidney on the right side, and there are microhemorrhages also.
Typical of PAN.
Yes. And then the plasma renin activity was high, and the child had anemia and low serum iron. So we were thinking of anemia of chronic infection like that, and but anemia was there, and then the serum ferritin was normal. So then the adenosine deaminase 2 assay was done in PGI Chandigarh, and so the deficiency of DADA2 was identified, and this is the deficiency that is. So the value was 20.9. The control is 195.6. And this is the genetic analysis, which has shown the homozygous pathogenic, the common mutation was found to be present. Say vasculitis with early onset neurological involvement with recurrent early onset stroke with skin and joint symptoms, hypertension, elevated inflammatory markers, renal involvement, and a polyarteritis nodosa with very young age of onset. In presence of parental consanguinity, DADA2 should be considered, and this is the commonest monogenic cause of vasculitis, autoinflammatory syndrome. That's all. Okay.
Thank you, Dr. Kalpana, for a nice presentation. It's a very interesting case. Today only we had a case of a PAN in our ward. We were discussing.
Okay. Okay, thank you, ma'am, for giving the.
Thank you, Dr. Nehal and Dr.
Stephanie,
Biju,
there is
please.
a question in the question
And actually,
chat.
Dr.
One second,
Donna
I'll answer that. I'll answer that.
Okay.
Yeah, I'll answer that question in the end. Dr. Biju and Dr. Nehal for Dr. Kalpana's case.
Shows the importance of genetic testing as well, like we discussed earlier. But this is a fantastic case. So because it's so
Thank you. At
changes
least you could show.
management.
Possibility of
So
bleeding is one thing that has to be highlighted. So if we are usually we will give aspirin, that will increase the chance for bleed also.
exactly.
So
Yeah, true. Yeah.
Dr. Kalpana, how was the renal functions?
renal functions were completely normal. Then the plasma renin activity was found to be high. And the BP was also transient, it was elevated, then it comes back to normal. Then sometimes it will come as elevated like that. It is not a persistent hypertension that was seen. But later on, child developed this erythema nodosum and the erythema reticularis was developed. And then the child developed this recurrent fevers with the sweating, etc. All these came late, and the CNS presentation was the initial presentation. Okay. Thank you so much.
Thank you. Very wonderful case, Dr. Kalpana. Thank you so much, Nehal.
No, just to highlight the imaging findings, the phenotype, recurrent strokes, especially hemorrhagic strokes, platinum infarcts, and inflammatory changes, especially in the basal system, preponderant system, should point towards the diagnosis of genetic diagnosis of DADA2 mutation.
Thanks. I think take-home messages from you, Nehal, and take-home messages from you, Dr. Biju. And meanwhile, Mansi, can you please share the certificates on screen
Dr.
and
Stephanie,
get
there's
the
a question in a question box by Dr. Akash. Can you read that question?
Akash. Yeah, please. आप बोलिए, Dr. Kalpana, वो question पढ़ लीजिए.
Okay. And the experience on TPA in pediatric patient, TPA, and how early have you used, and any benefits above the mechanical thrombectomy?
Dr. Biju, my resident is asking. Akash is my resident.
Okay.
That's the whole problem. Like advances in imaging have helped us in terms of diagnosis, but in terms of mechanical thrombectomy or intravenous anticoagulation, we still have a long way to go ahead. And most important reason is we don't get them in time. So, irrespective of, I don't think wherever you practice in the world, still like you don't get these children in time, and hence the evidence is lacking in terms of interventions. Although we have made huge strides in terms of diagnosis, that is why the management still has to include rehabilitation, very important when it comes to stroke in children. So
you. Meanwhile, when you are, you can stop sharing, Mansi, and then you can show the neurocon slide. Meanwhile, Dr. Biju and Dr. Nihal will give their 4 take-home messages, and Sangeeta may supplement in addition. And I just want to say that somebody's asked about the previous sessions. This is the 31st in the series of weekly webinars, and you have all available on the YouTube. And I think mails have gone to everyone from President AOCN account today for all the links, and they will be sent to all the participants of this for all the sessions. And I really thank all the presenters for having presented so well. Donna, doesn't matter, but you have to learn to log in before and practice. And really thank you for Dr. Kalpana Vijay to pitch in. And Dr. Kalpana, I am waiting for your take-home messages also after Dr. Biju, Dr. Nihal. And thank you so much for moderating it so well. So Dr. Biju, take-home messages.
Take-home messages, like I said, but I think I perhaps take this opportunity to thank AOCN for these excellent sessions. They've been fantastic, and I can still see that, like, despite overrunning by horribly overrunning, still like we have 88 participants there. So it is fantastic.
And Dr.
Thanks
Biju,
again to
what has been
Nihal for his contributions, and also to Dr. Sangeeta for her contributions. Yeah.
messages for the pediatric neurologist from a great pediatric neurologist?
No, I mean, in terms of, like, we still know very little. I think even the next time we see somebody with a dissection, even with a simple dissection, we still, like, wonder, like, how long to anticoagulate for. So that is where the evidence is lacking, and particularly immunotherapies for the arteriopathies. So I mean, even for cardiology, like we still don't know, like, whether to close that PFO or not. So, and there's still lots to be answered in terms of stroke. But like I said, like that has been demonstrated with all these presentations. The seeking help of the neuroradiologist is key in terms of just not the diagnosis, in terms of, like, which way to lead your investigations. Absolutely.
My suggestion to everybody would be who don't have, but neuroradiology meets are very important. Meeting has to be there with the neuroradiologist as well as a pediatric neurologist sitting simultaneously and discussing out cases. I think that gives the maximum information, and we are really dependent on the neuroradiologist. And Dr. Nihal, do you have all these articles lined up, or you are having that platform to keep on taking out while you're going? I mean, you are very fast in posting in the chat. I wanted to ask you before you give your take-home
He does
messages
the
as
literature
well.
search for us. Yeah.
No, I
Yeah, I
just
mean, but
type
how
in.
quick? No, how
I
do you
just
do
type.
it? I mean, are you
No, they're all there in my
Everything
hard
at
disk.
hand. Everything is at hand.
I just have to type in the keyword on the computer and comes up. So
so that means you download everything at the end of the
yeah,
day,
everything is
every
downloaded.
day? Oh, wow,
I mean,
great.
as
So,
per the cases we see, and
so your database of your gray
yeah,
matter is too huge, I suppose, yeah?
Yeah, you should attend
Gigabytes.
this. You should attend this Friday sessions. Yeah.
No, I have seen him very active in whichever sessions I have seen him. Very cerebral, very active, very aggressive, dynamic. Yeah, please, Nihal.
no, thank you again, Dr. Shivali. Just to emphasize, especially in all the conditions of pediatric, stroke is the most important. Immediate treatment is important. So first, to get the modality of choice is relevant. I would, as Dhiren has pointed out, CT is really not required for stroke, but the only limitation in India we have is most of the large children hospitals, the multi-institution hospitals don't have an MRI itself. So that is why the children get seen on a CT scan. There's a delay. You don't pick up small infarcts in MRI. Then you get an MRI done later on. So that time interval needs to be cut down. Emphasis should be made on the MRI. If you don't know what needs to be done, you need to call the radiologist. Even if it's not a neuroradiologist, he should be knowing stroke protocol. So what needs to be ordered. sometimes you see the clinicians put in the order and the scan gets done. And if it's an infarct and if it's a venous infarct and they do an MRA, when you ask them why did you not do an MRV, they said it was written on the request form and that's what we did. So at least I would request the clinicians to at least take a call with the radiologist reporting the scans, especially in stroke patients. See the initial scan, ask them to see the initial scans on table. We don't know if it's a hemorrhagic stroke or a venous stroke, arterial stroke. You need to put the exact parameters to get to the diagnosis of these cases. And Dr. Sifali has mentioned multidisciplinary meetings are helpful. Especially we carry out one on every alternate Friday with most of the attendees over here. Most of them are the private hospitals we join in. So multidisciplinary interactions with the radiologist is also important. Yeah, that is what I just want to let the attendees know.
Thanks. Dr. Kalpana, you want to add
Yes.
something?
Yeah, thank you,
Dr.
Dr.
Kalpana
Hiren
Datta.
Panwale, for having a wonderful presentation of varieties of radiological images. And thanks all the experts for their expert comments and empowering us and giving this latest knowledge. Thank you all the moderators and the presenters. And a special thanks to Sangeeta and Kalpana Vijay also. So it's a very important what we learned from this session, that the role of imaging cannot be denied, and there are varieties of importance of that imaging. It can confirm the diagnosis, which can even identify the etiology, establish the timing of the insult. Even it helps in the further investigations, whether we go for the thrombotic or hemorrhagic or venous and all. It also documents the evolution, can exclude the stroke mimics. Sometimes it also guiding the therapy, what therapy to be given for the decision and all. And it also gives the information about the prognostic outcome of the disease. So neuroimaging is the essential part of the stroke.
Yeah, Dr. Kalpana, Dr.
And
Kalpana
thank you,
Vijay, Dr. Sheikh Abdul, Dr. Sangeeta, anybody wants to add anything? Dr. Kalpana Vijay, Dr. Sheikh Abdul,
Yeah,
Dr. Sangeeta.
all the experts.
It was
all
an
the
excellent
panelists
session,
give
ma'am.
one or two line messages for us.
It was an excellent session, and thank you for giving me the time also. Anyway.
No, ma'am. It's our privilege and honor to have you. Yeah, and sorry about the technical glitch. Youngsters to understand. Yeah, they are overconfident sometimes with technical stuff. Dr. Sheikh Abdul.
Yes, ma'am. Yes. No, it was all the presenters were very good, ma'am. Actually, the only thing is that imaging wise, you are lacking. So that need to be emphasized, particularly in MRI, as pointed out by Dr. Nihal. So that is the only lacuna we usually see in day-to-day practice. That need to be addressed. Rest of the things are okay. Most of the things are covered.
Thanks. Sangeeta, I did introduce the Neurocon in the beginning. You want to say in the end? We can wind up the session. Yeah.
So even I would like to say thank you, Dr. Shifali, for giving me the opportunity to moderate this session. Very interesting session.
Thanks, Dr. Kalpana. Sangeeta, Neurocon, you have to call people, speak.
And please
I
post the
invited on
link
your
also
behalf
for the
in the
registration.
beginning.
Neurocon registration.
Yeah, it is. It is there. She'll post it.
On the behalf of organizing committee and AOCN team, I would again like to extend a warm welcome to all the pediatric neurologists across our country and from other nations as well to attend the 14th annual conference of Association of Child Neurology, which is being hosted by CMC Vellore this time. The dates are from 8 to 10th February. So please block your dates and register for the conference. The abstract submissions have been extended till 31st of December. So please submit your abstracts as early as possible. And we have an exciting academic schedule with one-day pre-conference workshop, including 5 workshops on neuroradiology, pediatric sleep disorders, electrophysiology, neurodevelopment and behavioral pediatrics, and pediatric epilepsy syndromes. And we have a full-packed academic sessions for next 2 days. So looking forward to meet you all at Vellore. Thank you,
Sangeeta, I also said cultural activities, so you please have more culture. I announced that also. I hope so, because some people need some brightness besides that.
We have an cultural evening on 9th of February 2024. Along with the wonderful academic sessions.
Thanks, Sangeeta. And the links will be sent, but we have made a YouTube channel for AOCN, so you can subscribe the YouTube channel. Okay, thank you so much,
ma'am.
everybody, and thank you so much, Dr. Biju, Dr. Nihal, and everybody here. And see you next
you.
week. Next week, we are having a talk on acute stroke management, and we have somebody from Canada coming up. So come and join the session next week. Thank you so much. Thanks a lot.
Thank you.
Bye bye.
Thank you.
It's
Good
fine.
night.
Thanks for the
Thank you.
compliment.
Good
Thank you.
night.
Thank you. Thank you.
Thank you, Dr.
Bye.
Biju.
Good night. Good night.